Hi everyone, this is Mr. Neil Wright here, also known as the Wax Whisperer. Thank you for joining me in my latest video. This is of a patient who attended with bilateral blocked ears, and that was the left ear, and this is the patient's right ear. The entrance of both ear canals are slightly narrow, and just the consistency of wax was a bit sticky now. There's a bit of an opening at the top, and I just thought, I was going to go in with an ear hook. And sometimes when it's sticky on the surface, the core's a bit harder and a hook's a good instrument. Now, I was reluctant to use a Jobson horn there because sometimes with a Jobson horn with this consistency, instead of removing the wax, the soft wax, you're almost spreading it like butter on a slice of toast. And I don't want that. Therefore, I've just put some olive oil spray in here. So it's medical grade olive oil. We don't use home grade cooking oil. This is medical grade, so it has been, I believe, sterilized to a certain boiling temperature to remove any impurities. And a spray applicator is really good to use because it coats it more evenly actually. And sometimes with drops, if you don't get the dropper, the syringe dropper, or some of these drops, you put the tip into your ear and you squeeze the bottle. It's just a bit more cumbersome, and sometimes they don't actually go inside the ear canal. With the spray applicator, you can put the nozzle in the ear, so you know when you do squirt it, it is being directed directly into the ear canal. And what the olive oil does in cases like this, where you've got sticky wax, it has a binding effect. In addition to lubricating the ear canal to help the wax come forwards and away, and also lubricating inside of the suction probe so it doesn't get blocked with the sticky wax. But it brings this wax together, and I've probably used this analogy a few times. It is a food analogy, but if you're making a cake of some sort, or a potato cake, fish cake, and you put an egg in there, the egg just helps to bring all the ingredients together. So sometimes with this sticky, kind of loose and wet wax, it breaks away in little bits, and ideally you want to bring it in, you want to bring it out in big chunks. And the oil's working quite well at the moment. You'll see once I remove all this wax, the base of the patient's ear canal is quite wavy, it's bumpy. And that might be one of the reasons as to why this patient is getting a wax impaction and build up. Because when you've got a bumpy ear canal, it restricts the migration of the epithelial skin. So the epithelial skin is the layer of skin that lines the ear canal, and as it dies and sheds, it moves sideways naturally out of the ear, a bit like a conveyor belt. And our ears evolved to do that, because if it didn't evolve to do that, then everyone's ears would be blocked full of dead skin, and I'll be even busier than I am at the moment removing that from your ear. So the ear has evolved to self-cleanse itself. So as the skin dies and sheds, it migrates out of the ear like a conveyor belt, and then you get another layer of skin growing underneath that. And any wax sitting on the surface of the skin is also transported out of the ear as the skin migrates. So if you can start to appreciate the ear canal here, it goes up and down, almost like a roller coaster, if you like. It's going up and down. So you've got these ridges, and the wax gets trapped. The skin gets trapped, so it doesn't migrate out of these ridges. It's more difficult for the skin to migrate when you've got bumps. And because the skin can't shed, then it's more harder for the wax to migrate. So we've got the view of the eardrum already. So this wax clinically may not be affecting the hearing much, if not at all, because the eardrum is in view. So there is a pathway of sound there. But nonetheless, obviously, this is quite a big piece. So we want to remove this. Now, there's going to be a bit of residue around the edge. We're going to leave that. I'm not too interested in removing all this residue. It may look big on a camera, but in real life it's not. It's minute, it's minuscule. I have more wax in my ear than this patient does. So, well, after the removal of this last plug. Now with the eardrum, you can see just to the right hand side, you can see the part of the eardrum there. That's the bone there, the white kind of L object. That's the patient's middle bone. So behind our eardrum, we've got the ossicles, which is the hearing bones. There's 3 of them. You've got the hammer bone, also known as the malleus, and that's normally visible when you examine someone's ear. So the hammer bone is attached to the eardrum. Then you've got the anvil, also known as the incus, which is the bone that you can see there. You don't always see that in patients. And in younger patients you do, because the eardrum in younger patients is more transparent, and as we age it becomes more translucent and eventually opaque. And then you have the stirrup bone, also known as stapes, and that's the smallest bone in the body. And we call that together the ossicles and the ossicular chain. And you can see there, it's quite visible, we can see the incus. So a bit of wax around the edge, I'm not too bothered by that. The patient's hearing fine. I don't want to just risk, patient, because of the anatomy of the ear, it was a bit more difficult getting access, and I don't want to, just that bit on the anterior canal wall, just trying to get that, it's not going to improve their hearing. And because of the anatomy of the ear, it's a bit more tricky. If the ear was a bit straighter, I would have probably just hovered over it, but it would have been difficult to get an instrument into that little gap in that angle. So this is the patient's right ear, and in both sides, the entrance to the ear canal is quite narrow. Now, when I perform the procedure, I actually stretch the ear myself using the endoscope, so I'm not asking the patient to stretch their ear. So I know quite a lot, and I do train some of the clear wax specialists. Well, I train all of them to do that initially, because whilst you're acquiring the skills to use an endoscope, it can be quite tricky. I probably didn't fully appreciate it until I started training people on maths, and I kind of realised, okay, it's not as good. I think for myself, even if you watch my earlier videos, you can see my techniques evolved a massive amount and become a lot more confident. But the endoscope's now almost like a third arm to me. And it's just it's like, I suppose, when you're driving a car or learning to swim. So that's probably a good example. So if you're a beginner swimmer, you normally wear your swim bands, or you might have a float to keep you, prevent you from drowning and dropping to the bottom of the pool. And as you evolve and you become a better swimmer, you can take those armbands off, the swim bands, and you may no longer need a float. Almost like learning to ride a bike. At first, you may have your support wheels, so it's like a tricycle, and then eventually you can remove those because you're more confident, you've developed a technique. And I would suspect it's the same with endoscopic earwax removal. It's very similar. So it's a learning curve. And at first, what most delegates struggle with is to use the endoscope tip to manipulate the ear canal. So most people's ear canals are narrower, and there's an angle there. You've got the first bend. So you have to stretch the ear open to enable to not only get the endoscope in the ear so you can visualise the wax, but also to stretch the ear open wide enough to insert the instrument. And so at first, some of the delegates can struggle with that, and that's understandable because they're still learning and trying to acquire the skill. So we can advise them, or we show them to either get the patient to pull their ear back, to stretch it for them, so it's a lot easier then. You don't have to use the endoscope to stretch it. It's one less thing to worry about. Or I know some audiologists sometimes, if they're fortunate enough, they have an assistant who can do that, or even the patient's family member. Now, when I perform it, I'm not asking the patient to stretch the ear. I asked one patient in the last year to do it. It's just the ear was completely swollen, so it was not a normal ear. But typically, I don't ask the patient. I'm using the endoscope myself to stretch the ear open, and the more and more procedures you do, like with anything, you become better and more experienced and more comfortable doing that. And our clear wax delegates are no different, and they do really improve after just using it. So you can see we removed the majority of the wax. I used a hook there just to remove the large piece. We used loads of drops there to bind the wax, and this was right up against the eardrum. Now, the eardrum at the top left, you can see it's slightly retracted. There's a little retraction pocket, but it's clean. There's no skin that's trapped in there. It's a bit inflamed, and that's because I think the wax was really impacted against that drum. Well, I hope you enjoyed that video, guys, and you're all keeping well and safe. And take care of yourselves. Remember, be nice and be kind to each other. Thank you. Bye.